Hello, DM is a 42-year-old man who presented to the clinic for a follow-up reading of his TB test, and this was following his trip to India. The TB test resulted in positive due to a greater than 15 millimeter induration reading, and his past medical history is notable for generalized idiopathic epilepsy and alcohol use. The patient has reported no seizure activity, though. Objective information: the patient denies fever, dyspnea, hemoptysis, and cough. They had an anterior and posterior chest x-ray, which was negative for lesions and cavitations. All lab values were within normal limits. For his tuberculosis, the latent TB, since there are no active signs of infection, positive TST, and there's no cavitations, isoniazid 300 milligrams once daily for 9 months would be appropriate. There was some concern with interactions, but we'll go over that in a second. Vitamin B6 or pyridoxine 25 milligrams once daily concurrently could be used to decrease the risk of seizures. And some counseling points should be to take the isoniazid on an empty stomach 1 hour before meals, to not consume alcohol while on the medication. We should definitely emphasize the adherence for the patient and the importance of it. Counseling the patient on warning signs of neuropathy, so basically unexplained anorexia, nausea, vomiting, dark urine, paresthesias of the hand and feet, weakness, fatigue, and hepatotoxicity, so if they have any confusion or jaundice. Also, they should watch for any signs of active fever or active infection, which includes fever. Also, they should take the antacid, I believe it was the calcium carbonate, at least 1 hour before the isoniazid, because there can be an interaction if taken at the same time. As for their patient's seizures, they have been currently controlled on the carbamazepine 300 milligrams, and they've been taking that 2 tablets by mouth twice a day. And to switch the carbamazepine would really be a big deal, so we should just keep it on because you don't want to have to worry about weaning them off and then starting a new drug, especially since they're already controlled, and then the risk of the other drug not keeping them controlled. Lastly, their alcohol use: counsel the patient on increased risk of hepatotoxicity with the concurrent use of isoniazid and Tylenol. There's also an increased risk with the carbamazepine and the Tylenol. Also recommend changing the pain medication from Tylenol to NSAID since there's no kidney risk in this patient. And lastly, the patient should follow up in 2 weeks with the primary care provider for their INH treatment and 2 weeks with neurologist for seizure control. Thank you.